Welcome back to another episode of One Clear Vision. I'm your host, Nikki Check, and in studio with me, I have Dr. Sophia Capo of ABC Optometry and Vision Therapy. She is Okanagan's only dedicated center for children's optometry and vision rehabilitation. That's quite the mouthful. Welcome.
Thank you for having me again.
Welcome. So today the episode is going to be covering research in vision therapy.
Yes.
So over to you. What is vision therapy?
So the easiest way to explain vision therapy is to compare it to physiotherapy. So physiotherapy, you go in, you have an assessment first. So that's when they come to see me and you'll do a visual skills assessment. So that's when we'll measure the stamina, for example. We measure the focusing system. We measure the alignment system. And then we can say, if there's a deficit, is there something that research shows that we can train? If there is, then we bring them in for a vision therapy program. Okay. So what that program looks like is weekly sessions where we look at strengthening the areas of deficit. So if the stamina is low, like we talked about stamina last week, if the stamina is low, we're working on increasing the stamina. If the focusing system is inflexible, we look at increasing the flexibility of the focusing system. And we have exercises that we can do that are proven, that have been shown to increase those specific areas that might be deficient. Exactly. So these programs, just like physio, you go in once a week and then it's a one-on-one session. And then at home, you're expected to do some sort of home exercises to keep up during the week.
So if this, then that. So what are the common visual conditions that vision therapy could help or will help?
So the one that we know vision therapy is the gold standard treatment for is convergence insufficiency. So remember, convergence insufficiency is when the eyes don't want to turn inward to do things like read. So if the eyes have low stamina, they have maybe a slouchy posture, they don't want to turn inward, vision therapy helps to teach the eyes to coordinate better. Now remember, that has nothing to do with visual clarity. It's just, can the eyes turn in? Do they have the stamina to maintain that position to be able to see? If they have that condition, vision therapy is always the number one thing that we recommend, because we know that glasses don't fix convergence insufficiency. Surgery can't fix convergence insufficiency. So our training program is the only treatment that we have, and it is a dang good one because it works.
So what are the different approaches to vision therapy? Is it one thing fits all, or?
So there are some different approaches. And I've taken courses in both types of approaches because it's important, I think, as a provider to understand everything that's going on out there. I choose to only practice one approach, and that's the evidence-based, more standard vision therapy treatment. Now, the reason why I lean this way is because I work with the medical providers. So in medicine and in, high-level optometry, we're always looking for the best level of evidence, the highest level of evidence before we're recommending a treatment. Exactly, okay. Proof. But just like with other providers, just like with physiotherapy, for example, you can have providers who are more holistic in their approaches, or who say, we're going to do things this way because it's a little more naturopathic or it's a little bit more alternative. And there's a role for all different types because there's people who enjoy a little bit more of an alternative method in the community. I choose to practice a lot more evidence-based. So my methods very much follow the rigorous protocols of the research. And that's because vision therapy can and will help if we have a condition that we can treat and fix, if we know that we have the literature and the data that we can fix things. But if we don't have that data, we can cause, harm. And by harm, I don't mean we're going to, make somebody's eyes worse and now they're going to have, double vision. I'm not mean they're coming in with no problems and they're going to leave with problems. That's not what we mean by harm when we talk about research. What we talk about when we mean harm is more of like a risk. So let's say a child comes in and they have difficulty with reading. And I do my assessment and I don't find a convergence problem. I don't find, a focusing system problem. If I enroll someone in vision therapy when we don't have a problem that we really can fix, then maybe we're causing a financial harm because now these services are not covered fully by, the government. They're not covered necessarily by extended health either. Some providers do cover them, but it's not very common. And so if these parents are paying out of pocket for 10 sessions where we don't know for certain that we can fix things, then that's a financial harm. The other type of harm we can cause is a delay in other treatment. So let's say they're coming for a vision therapy program and really they should be, going for a reading coaching. They should be going for extra reading help, or they should be going for tutoring, or they should be saving that money for a neuropsychology assessment. That's a different type of delay, a different type of risk that we might be causing by doing vision therapy in cases where we don't actually have data showing vision therapy will be helpful.
I just want to say that I appreciate as a mom of 3 and a granddaughter, I appreciate the evidence-based practice or approach because it gives me reassurance that you're going to think something, you're going to test it, you're going to confirm, and then you're going to put a plan in place. So that let's talk about the next part of that, which is so you think all these things and you want to deploy vision therapy. Now, how are you going to measure the effectiveness of that therapy?
Yeah, it's a good question. So just like you said, we do our assessment and we're taking our baseline measurements. Okay, so I already know exactly where the deficits in the system are before we're starting a therapy program. We're also looking at 2 other important areas, which are one, the subjective effects.
Love reading.
Yes. Because if a child says, I have double vision up close, and let's say they're diagnosed with convergence insufficiency, I want to know, what level in reading are you working on at school? Are you behind in reading? Are you not able to do your homework, or are you not able to succeed in school because this is holding you back? And then we have a survey. We have standardized surveys that have been, used in children ages 6 and up that show that if we measure at the beginning as a baseline, and then we measure after our sessions to see if there's been progress. So if we have, our measurements that we're taking clinically that I take, those aren't necessarily measurements that parents care about or measurements that the kid cares about. Because if they come in and, I measure and I say, your stamina is very low. And that kid says, well, I'm really great at reading and I'm succeeding at reading and I have no issues and no symptoms. Well, we're not going to put them in a therapy program because if there's not a functional problem, then what are we trying to fix? But if they come in and I find a deficit in stamina, when I'm done my program, if the stamina is better, I want to also know that their reading performance is better and that their symptoms are better. They're no longer getting headaches. They're no longer getting double vision, because those are the things that are important to them. Not necessarily important to me clinically when I'm writing down my measurements.
So what role can parents or grandparents or guardians play in supporting that? So you opened the video with liking it to physiotherapy. So often you get exercises or something you have to do, homework. You have to do at home. So what can we do?
So parents at home play a huge role in their child's vision therapy, in their vision therapy process, because the parents are the ones who have to say, hey, we're going to do our exercises right now. The exercises, usually like 10 minutes a day is what we would ask. So once a week it's in office, and then 10 minutes per day at home. If we can get a little tiny bit of exercise in, we see so much more of a benefit than if we just come in 1 day a week. And so I've had the best success that I've had, hilariously, with parents is when parents say, you're not allowed to watch TV and you're not allowed to go on your phone until you do your vision therapy exercises. And those kids are the ones who get better faster because they're doing it. And we know that if you do it, if we have that compliance and we're doing our exercises, then we're going to get better. And if we're in a therapy program and we're not doing our exercises, then we're probably not going to see an improvement.
Which, I mean, this just transfers. This makes sense. If
It's
you're
logical.
in piano lessons and you don't practice piano, guess what?
Exactly.
You haven't improved from the last week's
Yes.
lesson. So can you discuss recent research or studies that have influenced your practice or this mission of evidence-based?
Yeah. I think in order to understand kind of research, we have to backtrack and just say, what is good research? Because I think everyone out there is very aware now that you can go online and you can find an article saying anything these days. And that's not how scientific research works. So how research works is you ask a question and then you perform a study to answer the question. And we shouldn't use our biases to say, this is how I think the answer to the question should go. We should just ask the question and then let the answer show itself in the research. So a good study, let's say a high level study, I call these studies that change our minds. So a study that is big enough that it's going to change our mind is a study that's randomized, which means there's two different groups. There's a treatment group, and then there's a placebo group. So the treatment group is the group, let's say, that actually gets the vision therapy. And the placebo group is the group that gets a fake vision therapy. So they're going to come in and they're going to do random exercises that have no proof that they actually do anything. And in order to show that vision therapy is actually doing something, we need to see that the treatment group is significantly better off than the placebo group, than the group who just did the sham vision therapy. There also needs to be a large number of participants in the study. So if I have 3 participants, I can't say this is great for every single person who has this condition. And so in vision therapy in particular, we have some really great high-level studies showing that if someone has convergence insufficiency, we can fix that with vision therapy. And these are like multi-level studies all over the US. There's like hundreds of participants, and it's widely accepted that we can do this. We can do vision therapy for convergence insufficiency. And convergence insufficiency, which is great, happens to be the most common eye coordination problem. So the one that's most likely to be found, we do have a treatment for. But other things such as, learning related issues or dyslexia or those types of issues that children might have with reading, we don't have a lot of data saying that vision therapy can fix those things. And so from an honesty standpoint and from an integrity standpoint, it's very important to be transparent in not just the philosophy and the treatment methods that I'm using as a provider, saying, I'm going to take a more evidence-based approach. It's also saying, well, this is a condition that we can treat, or this is a condition that I don't think that we can treat. And another very common misconception is that expert opinion means a whole lot. And believe it or not, when we look at the evidence pyramid, so like the highest level of evidence that we have are these sort of reviews that look at every single trial that's ever happened, every good trial, and then it gives you the opinion. So it takes the randomized trial that we just talked about, but hundreds of those, and then says, okay, now that we have 100 really good studies, this is what probably the answer to the question is. The lowest level of evidence is actually expert opinion. So I would consider myself an expert in vision therapy, but my opinion on what I think is going to happen is actually the lowest form of evidence we have. And we only use expert opinion when we don't have evidence available. So if someone comes in and they're like, well, I have this issue, then we have to say, okay, you have an issue. What are the other treatments that are available? So like, are you a surgical candidate? Are you a glasses candidate? Or should we be spending money on different types of therapies or different types of assessments? Sometimes parents come to me and they've already tried a million different things. And I say to them, we don't have a lot of good evidence saying that this is the be all end all and that this is going to fix the problem. But the parent says, I want to try. And in those cases, as long as we are honest and as long as we are integritable in the way we are providing our care, sure, we can try. And if you want to try, I'm on your team and I'm there with you every step of the way, as long as you understand what you're getting and as long as you understand that we don't have a whole lot of research in whatever area that we're dealing with.
So to your point previously about being able to go to the internet, and we Dr. Google all the time. So we're coming in with a preconceived notion that might be contrary to considering vision therapy. How do you address some of those strong opinions or misconceptions or controversies around what the parent is thinking?
I think the first thing needs to come with a very strong and gold standard assessment. So sometimes people come in because they've gone online. They say, hey, my child has all of these symptoms. I think they are going to need vision therapy.
Sorry, we do that.
But you know what? It's good because at least they're finding parents are looking and they're really great at finding solutions for their children because that's what they want to do. They're like, my child is struggling and I want to do everything I can to help support them. And that's their job as a parent.
Absolutely.
But my job as a provider is to make sure that these patients and these parents don't get taken advantage of. And so my job is to make sure that they're only getting the treatment that they need and they're getting the treatment that's backed by the appropriate amount of evidence. And so I have these conversations with parents all the time. And it's first, we're going to start with a gold standard assessment. And the gold standard assessment, remember, includes those eye drops for kids. Because a lot of people come to see me and they haven't had those eye drops. Excuse me. And so if they haven't had the eye drops, then I don't even know if maybe they just have a hidden prescription.
Yeah.
And so we need to make sure that we're doing our gold standard assessment prior to any recommendations that we're giving. And then once we give those recommendations, we follow up very frequently. So for example, my vision therapy program is usually 6 to 8 sessions, and then we do a reassessment. So what that means is we measure our baseline, then we're going to do an intervention, and then we're going to follow up quickly to make sure that that intervention is working. Because if we do 6 sessions of therapy, we do a follow-up, and we have found there's absolutely no change. Like no change in the stamina, no change in the ability, then continue. Exactly. So then we say, well, either one, are you actually doing the exercises and are you doing them properly? So let's see that first. But then maybe this isn't the solution for you. Maybe this isn't working and maybe we shouldn't continue because from an ethical standpoint, if this isn't working, then we're going to stop and you can explore some other options.
Which as a parent,
parents usually appreciate that.
Very much appreciate that. So I remember, and I don't want to call it an incident, a conversation with my doctor who had so this is 25 years ago, who had just started his practice. And he said, and I won't get this exactly right, but I remember it had an impact. He said, I'm only going to be a really good doctor for you for 12 or 15 years because then I'm outdated is what I took away. So what do you plan to do to continue improving your practice and the services and all of the things that you need to know and learn all the time that's a really great question. And we do have data saying that doctors are in their prime for, I think it's
fibbing. No, he was not fibbing. After, I think it's after the first 5 years, because the first 5 years you're new. Then after that, it's your prime. Yeah. And then after your prime, then it's just because you fall into some habits. Mm. And then also data changes every single day. And if you're not keeping up to date with that, then that's an issue. But what I think that doctor missed is that there are checkpoints, especially in Canada, to make sure that you don't get left behind and that you don't get dropped off. So we know that those things happen. And so there's actually courses that are mandatory for all doctors, including optometrists, to take every year to say, okay, you are going to stay up to date with this research, because if you don't, then you're going to not be able to practice anymore. You're going to lose your license. So what I do in particular is I try and go to all of the high-level conferences every single year. I've lectured at some of them, and I lecture internationally as well, just because I right now am in that prime period where I have so much data and knowledge that I'm sharing to other people. But we go to all of these conferences and we like to see, okay, where are the studies right now? They might not be super high level. They might not be at the point where they're changing our minds, but they're out there and they're in the lower stages. So we're saying, okay, we're going to keep an eye on these, because the second they become high level studies, we got to change the way we practice.
Fascinating.
Because we can't be ahead of the data. I will change my practice the second there's a study that says we should change our minds. That's when we will change our practice, and that's when we'll change what we have to do. But right now, we have to go with whatever the current gold standard is. And especially one of those things right now that's big is amblyopia. So remember we talked about, briefly last episode, we talked about the patch. Mm-hmm. There are a ton of resources online. If you search amblyopia treatment, that will say, we're doing like vision therapy for amblyopia, get rid of the patch is outdated, we don't need the patch. And you know what? There are a lot of really great lower level studies right now that are coming out that are showing, oh, well, maybe the patch is going to be not the gold standard. Maybe in a few years, the patch is going to be out. But right now, the patch is the most affordable and most effective treatment. And the studies that are comparing the patch to these really expensive online training programs are still showing that the patch is equally effective.
So it stays until evidence shows us different.
So the patch is the current gold standard, and until the current gold standard is beat, that's when we will change our mind. And so right now, like, even though when you Google amblyopia treatment, you're going to find hundreds of articles saying, stop patching, go see a vision therapy practice, like go spend all this money on vision therapy. The patch is actually still the gold standard and it still works.
So if it's still working, another reason not to Dr. Google and to come and see you. It's your lane.
Yes. Or if you're going to Dr. Google, that's amazing. But then come talk to an evidence-based provider. Yeah. Come talk to someone who is going to give you an accurate representation and an honest opinion of what's actually happening in the environment. That could then change
that parent's mind. Or
100%.
Mind. Okay. So in the time that you've been practicing and the vision therapy disciplines that you've deployed, do you have a memorable experience or a patient outcome that moved you, or that you said, oh, this is why I do what I do?
Yeah. I can think of one that is like still to this day, I get chills because, I was out in public. It was like a networking event that I was just talking to a random parent, and, the parent, was like, oh, you're a children's eye doctor. And said something like, my child wears glasses. And I had asked like, oh, well, did they have the gold standard exam? Did they get the eye drops? And she said, no, like he's never had that. But now he's being investigated for ADHD and he's seeing a pediatrician, and the pediatrician is about to put him on medication, but we're holding off right now. And I said, like, why don't you just come by, bring him in and let's see what he has. And he ended up coming in for a visual skills assessment. So we looked at his stamina, we looked at the flexibility of his system and all of those other components that aren't measured in a routine eye exam. We did the gold standard dilation drops. And what we found was he did have a convergence insufficiency. So he had an eye coordination problem. And I said to the parent, eye coordination problems are more common in children with ADHD. So it's possible that he has all of these things. But let's try and relieve this barrier before we put this child on medication. And so the parent was like, yeah, I'm hesitant about medication. I don't want to do that anyways. Let's do it. And we only did 6 sessions of vision therapy. 6 sessions. He came in for 6 weeks. The mom was very passionate about getting the homework exercises done at home.
Absolutely. I could have.
And then started school, was going through school. I think the child was in grade 4 or 5. Mm-hmm. Reading became great. And all the school performance increased to the point where the pediatrician was like, we don't need to do medication anymore. And so with these types of things, it's like, well, even if they did coexist, even if both of those things happen, we removed a barrier enough to get this kid to become more functional and have better attention and be able to read and be able to succeed in his school program, to the point where, and all it took was a simple 6 sessions of a training program that this mom didn't even know existed until we just happened to meet at this networking event.
So again, I want to take this opportunity to tell anyone watching, anyone that knows anyone with children, please, please, please share this information. Dr. Capo, you're so great at educating it and making it so simple. I love the analogies and the examples you give for me. As you talk about it, I retain it and then I go reiterate it to others like I know so much more. So I thank you for your dedication to the work that you do, and really encourage people to fill out the form, bring their kids in and get that gold standard test. And that's a great place to start.
Thank you. Yeah, that was my goal of wanting to share this and wanting to do this series is that people just don't know. People don't know, and you don't know what you don't know. And so if you empower people with knowledge, then they make really great decisions for themselves. And that's what we're trying to do.
Love it. Thank you very much.
Thank you.